transitioning, and they basically said, we really want you guys to, can you rethink this? And so we agreed to do that to try and, it represents some changes in practice for our case management unit. And those folks are stretched pretty far these days anyway because of the demand for services. But I think upon further discussion in-house, that we are going to be able to comment.
Yeah, I always understood the difference. I also understood that this was a new initiative. And I also understood that conceptually, it sounded like it had great potential. So it's not that we've implemented it and it has not produced good results. Basically, it's had trouble getting off the ground.
I think it's the results have been mixed. One of the things that was a discovery for me is that I kind of assumed that if anything could be a motivator for somebody to take a look at their substance use and take advantage of treatment, it would be the potential loss of their kids. And yet we're finding that maybe it's just a particular group that are targeted for this. This is only a sub part of the CYS parents that we deal with. Many of them are very, very resistant. And we've had a lot of difficulty connecting and just getting them to engage in the program. So that's been part of the challenge.
Well, when you hear stories about parents going into the bathrooms at Chuck E. Cheese during their kid's birthday party and shooting up and dying of an overdose, it's a pretty big problem. I would hope. I mean, I don't want to pour money down a black hole, but I would hope that we would at least give it a shot because the problem is simple.
Well, to clarify, children and youth was never going to stop funding. It's just we were talking about maybe trying a different strategy, a different approach.
Okay. Thanks.
Which I'll pretty phenomenal. For Cumberland County Health Choices, it's an increase, but that's because we put a padding in the budget, and I'd done a resolution after they had already put the budget figures for this year, for 16. So there is a little bit due to MA expansion and the number of consumers that have been members that we have gotten. It definitely has increased our Health Choices revenues. Perry County, we're still tracking about the same as we are this year, so I left it around the same. We're looking at increased membership. We've been, basically approximately a little less than 1% actually stays in the county. All the money that comes in goes back out to our CABHC, who is our collaborative MCO, I guess, administrative entity. So, and then they in turn fund our Form Care, who is our actual provider, MCO of the services. So basically, we are just sort of a pass-through agent, but we do get about 1% to keep in the county, which goes towards part of my salary, Jack's salary, Sylvia's salary, Ryan Simon's salary, and then some of our staff on each of our departments that we were able to transfer the money between.
And without choices, there's no county.
And there's no county match on it.
It's 100% state.
Jack or Sylvia have anything to add?
I was going to say, I think that with Health Choices, actually there was a 28% increase in eligible members in Cumberland County, and actually about a 20% increase in Perry. So that's pretty significant for Jack and I, the behavioral health piece. And talk about new programs. I mean, there's a lot of things that we do in Health Choices around detox and rehab beds and access to psychiatric care, a lot of changes about behavioral health rehabilitative services for children and adolescents, and especially for those children on the spectrum. Increase in rates for providers. I think we increased outpatient rates a while back, and just at our last board meeting, increased rates for some of the BHRS services. I think one of the things that we try to do, at least on the MH side, is that although we don't pay the exact same rate as our managed care partner, because they have a little more resource, we do work to try to keep our rates above the flat medical assistance rate because of the significant access issues if you are not. And, you know, one of the things you don't want to do is have a real unbalanced system of payment where providers will take these folks but will not take the county-funded folks. So I think that's really important. Around health choices. Housing, Shepherd's Crossing was in part reinvestment. So I think that's something that's really important to think about the benefits that we receive from health choices.
Yeah, with health choices, we're not allowed to make a profit. We exercise the county right of first refusal to be involved in managing that. And it's a smart decision because then we can balance the base funding with the medical assistance funding. But on the physical health side, the private insurance companies can earn profit. We can't. We're capped at a 3% surplus, but we can keep up to 3% and use it for reinvestment programs. And in the last couple of years, we've had good years financially. There are years that we don't have a surplus. There are years that we have to dip into our risk reserves to cover the costs. We're funding it like we're an insurance company. But one of the things that I'm excited about is, part of our problem in drug and alcohol, I just said that MA is paying for treatment, so it's freeing up. But the new problem is finding a bed, whether it's a non-hospital detox bed or rehab. And so some of our reinvestment funding is being used. We're negotiating with Gudenzia, Common Ground in Harrisburg right now to expand the capacity of their non-hospital detox units so that we can accommodate more people. And actually, both their detox and the rehab, because we're going to be able to expand both detox and rehab facilities.
So this is kind of a double whammy then. If you've got more effective demand because more people are covered, but you don't have the supply of services, you generally, in capitalism, that means that the cost of the scarce resource gets bid up, and then you wind up paying more until capacity expands to meet it. Are we sort of, is anybody trying to make money on this?
There are, I can only speak to the DNA side, but a lot of those efforts are targeted to resource individuals and families. There's an emergence of really expensive rehab programs, and the insurance rates are much higher than the MA rates or the county rates. But then there are even programs that don't accept insurance. They want a certain payment up front, cash on arrowhead, or at least a portion of it. And some of those have been criticized, and they should be, for taking advantage of an epidemic. And so there's concerns about that. I don't think we're seeing that in the providers that we contract with for county and for medical assistance, because they have to be willing to accept the rates that we're offering, that it doesn't go the other way around. If they don't like our rates, then they don't contract with us.
Right.
Okay. And it's just quick, it's back to what Lisa stated about not being able to find places for kids, particularly detention. Are you seeing, this would kind of lead one to think that, you might get these for-profit detention facilities. Are you seeing that, or is it just everybody's trying to multiply the best way that they can?
Everybody's trying to get by. Well, there are providers that are more, but we try to stay with our local Abraxas and stuff. And it's not just with detention. Some of our more tougher kids to place, like JPO just had a kid that I had a contract with White Deer Run for, because nobody else in the state will take them. The only place that would take them is a YDC, which we haven't used in many, many years because they're very expensive, like $400 or $500 a day. So they were able to find one place in state to take this child, but it's the tougher kids to place that we're having trouble finding places for. And then they sit in detention and shelter longer.
I have one general question. Everybody seems to think, or I think there's consensus, that the expanded MA was a great thing. Are there still any lingering, and I think this is discussed at some of the previous board meetings we've had. Are there any transition problems that still persist going from the previous governor's system?
That's done.
That's all
That's
taken
all,
care of?
it's all, the healthy PA stuff is all gone. It's all,
So there's
yeah.
no financial ripples to anticipate,
Right.
that's
There's still financial
Still
ripples.
some
We're
financial
still-
ripples,
We're getting
but-
another phase to adjustment effective, well, we're supposed to get it by June 30th,
Yeah,
but,
we got today.
yeah, we just got a letter
We
today.
just got a letter today. You didn't see the ship because I forwarded it to Jack, so I guess. It talks about adjustments to the health choices rates based upon the new information from MA expansion. So those, so some of those,
I didn't have a chance to look
because
at it.
I looked at it, there's different categories of MA expansion that folks fall into. Some of the categories went up, some of the categories went down, so at this point, we don't know what the overall impact is, up or down. We just got that today.
Yeah,
So that's a function of MA expansion and health choices dollars figured out. It's not really a function of healthy PA. Is that?
When you said you're mostly over the hook,
The healthy PA thing is fine. The state and the MA expansion, they're still trying to figure out the true impact and what our rates will or won't be from an actuarially sound base
so
per the state.
They set rates based on actuarial analysis.
which is a good thing.
Yeah, but there was no history with MA expansion.
Right.
So you really had, actuaries look backwards to figure out the
Right,
future.
so if you had to conjure up your own crystal ball, what do you think?
What do I think the rates look like today?
What do you think is going to happen to them after the actuaries accumulate some more history?
I don't think there's gonna be that much, I don't think with the rates we got, we didn't get whole rates. I don't think with the shifts that we got today, there's gonna be a whole lot of changes in the rates.
Yeah, my guess is that, what they might not have anticipated, and I'm remembering that Scott is commenting on this, that they projected a lower penetration rate in terms of the number of MA expansion who were going to access behavioral health services. So I think that there might be a slight increase. But the other part of the story is that because this was there were risk corridors. Right. So we had protection on either end. If it was way under, we'd have to give money back. If it was way over, the state shared the risk of that. So it wasn't one of those things that had us really in a precarious situation.
Right. And because the state was under projected expectations, we, being CMHC, gets resource back from the state because they were under what actually transpired. So this kind of still pretty well balanced out.
Okay. So like with our public safety system, we know we have a huge expense, millions and millions and millions of dollars coming because we have to put in a new radio system. Right, so human services doesn't have to have a radio system, but you have the increase in population, you have unfunded mandates. The next 3 to 5 years, 25 words or less. What are the big things we gotta watch out for? To say nothing of budget impasses.
Are you talking health choices or base? Because they're real different.
25 words each.
With health choices, I think the big issue is they're trying to do a better job of integrating physical health with with behavioral health care. And we're just at the beginning of that, and it's all kinds of problems.
Yeah.
Just trying to get a way to share data, just a starting point to share data. So that's, I'm sure, going to be a struggle for years to come in all sorts of stuff.
Yeah, I agree. Probably the biggest.
On the base side for DNA, I'm having trouble seeing past this podium now, but we're losing more lives each year. And I think that some positive steps have been taken by the state policy-wise, but we're a little bit behind some of the other states, and so it's going to take a while until we establish home about that. And I think we will need some additional resources to respond to the growing number of people who need treatment, who need it rather promptly. Because the consequences, the heroin that's available is so plentiful, it's so cheap, and it's so potent, that the consequences of relapse are quite different than they were 15 years ago. And we're seeing that in the increasing number of overdose and people who don't survive with overdoses.
Well, frankly, it's the thing that surprised me the most. I mean, we knew that with the Sandusky legislation, you guys were going to get swamped. You got swamped. We planned on adding the resources. We've got this heroin epidemic. And either people aren't being steered to us for treatment. I mean, we know they're going to prison. I expected our system to melt down before this.
Yeah, well, I think the providers are stretched to the max. We're kind of strained.
I think for health choices as well as space, access, because of lack of psychiatrists and medical professionals like certified registered nurse practitioners, it's only going to get worse and worse. I mean, we know that, and this impacts both health choices, I mean, it impacts everything. Fewer people are going to med school, fewer people coming out of med school. Of the fewer people coming out of med school, even fewer people are choosing psychiatry. That's going to have a huge impact. And it's a huge factor in access issues.
So we do you want to talk about MH and IDD?
You want to go first?
Well, on the ID side, what the state would like us to do is serve more individuals in the community, utilizing natural supports, community supports, less emphasis on the government, funding. Surprise, surprise. One of the issues that we have with that is the lack of the frontline staff, and that's one of the things that our providers are having an issue with now, is making sure that they have staff to cover this and they don't have it. Some of it has to do with the laws about the insurance. Some of them are only hiring folks to work 30 hours and less, so they don't have to pay insurance. That's a big issue. Just their hourly rates aren't going up like they should. And so now we are experiencing a war between providers, that this provider is paying a higher hourly rate and benefits, so the staff from these agencies are going over there as it works. So, this year we had less development of like the community homes, more serving people in their homes, more emphasis placed on finding individuals with disabilities competitive employment instead of shoulder workshop, those kind of things. So I think that's what we will see this next year too, same kind of strategy from the state.
On the MA side, as Dr. already talked about, MA expansion has had positive impact on our base dollars, especially treatment, most specific to outpatient and targeted case management. We're seeing probably about a 15 to 20% reduction in contracted amount and what we get paid historically to what we projected out for this year. That's not true for all the treatment services, which is kind of interesting. Partial hospitalization has shown no change. It's actually the extended acute care unit, which is inpatient psych, we're actually gonna spend more this year than we've spent probably in the last 4 years, for whatever reasons. I mean, it's just, you know, so we do expect to have that, some savings from MA expansion, especially with outpatient and targeted case management. I would think we'd see some with partial too, but we're not seeing it yet. So that's a plus. What we're gonna look at, we have had several things I think that are significant throughout our communities, not only with the increase in population, but with that kind of increase, we're looking at a couple different things. Number one, crisis intervention. We have not had any change to our contracted providers' number of crisis workers. With that 5% increase in population, we have people literally in the ER waiting to get crisis services. So one of the things we're looking at is expanding crisis workers. We're having some data collected around, are there times do we scatter schedules? I mean, how do we better manage some of this? That's one thing we're looking at changing. Residential workers, again, as Sue has said, for our residential programs, those individuals have had absolutely no increases for years. They are supporting individuals who have more and more intense need. And we're also hoping that we'll have resources to look at some salary increases for our providers for those folks as well. Access and solving access. I mean, there's a couple different evidence-based kind of programs around access that I'm working with Stevens Center on implementing, and one's called Open Access. So hopefully that will get off the ground next year, which I think will be a huge plus for people around the access issues. And also some program development. We really have a need to develop some very highly specialized kinds of programs for a small number of individuals who have just major significant need. So we would like to look at the opportunity to develop those programs. We have 3 individuals currently at Danville State Hospital who, if we were able to develop a highly specialized program for them, would likely be able to retain. So that's just one example of what we're looking at.
On the dollar side, on the MHITD, there's a slight increase to our state grant, and that was due to our early intervention funding. They come through with our first re-budget last year, and that was our initial allocation this year, so we're just looking for it to stay status quo for next year. As far as subsidy, that has not changed since I started here, and almost 16 plus years ago. So, and as far as our biggest expenditure is the salaries. The salary increases is what's hitting us the hardest, and we will probably end up using projecting about 46,000 of our fund balance next fiscal year, and that is our billing for our medical assistance, waiver, and targeted case management services that we bill for, but we can't, we've got our staff maxed as practically as to the number of units that they can try to pull down in a 37-hour period. And so, and we're trying to increase that revenues, but if those revenues don't increase, this money was left over from 4 years ago. So now we're starting to eat into it a little bit. And especially with the pay increases, that's really gonna hit us this year.
Any other questions, comments?
Can you give us a real quick who's up, who's down, and where we are altogether? Hear the show.
Subsidy?
Subsidy.
Subsidy-wise, children and youth is up. Drug and alcohol staying the same, and MH is staying the same. 240 only has a very, very small increase. 255 is up,
That's aging.
sorry. Aging is up in subsidy, and community services is up a little bit in subsidy. Insurance fraud staying the same, there is no subsidy in that fund. 130, the criminal justice and IP planning is up. With under supervision, there is no subsidy in that fund.
So we're just going to do this overall.
Two separate on the page. Overall, subsidies up 592,000 in total for the fiscal funds.
Any other questions, comments, thoughts?
Just, I guess I had a question on when we talk about the MA expansion, if my memory serves me correct, the initial year, which we missed because the prior administration didn't want to take advantage of it, but it would have provided for 100% federal funding reimbursement. And I believe, where are we now? Are we getting 90% federal funding reimbursement for the amendment?
That's a good question.
Yeah.
Commissioner Wright. I don't think we're at the 90% yet. I think we might be somewhere between 100% and 90% in
That's
terms of federal reimbursement. But 90% will be before, when we reach that level. We maintained at 90% federal funding and 10% state funding.
Well, I mean, certainly what we've seen through the state's, embracing the expansion is that we're able to serve more people, especially with mental health issues and also with drug and alcohol. And I think you've kind of explained how that's worked the benefit here in Cumberland County by freeing up other dollars that we can also, return and devote to drug and alcohol services. So
I think somehow too, in the process, we used to have 11 different categories of eligibility. And that, well, I thought there was even less. I think it was
I
four.
think it's down, that's worse than that now.
Yeah. And in the simplification, there were some categories that were funded by state money only, Medicare needy. And those now fall into this MA expansion. So they were like 100% funded by the state, and now they're somewhere between 90 and 100% funded by the feds. So I think that's been a bonus to the state.
well, it's certainly been a benefit in terms of considering the flat funding that we've seen in all these other areas. At least there's some relief with respect to the additional funding that we're getting from the federal government.
Yeah, I just think the thing that scares me, and it's my job to be scared, is that the objective conditions are such that the demand for your services are going up. We've seen it most glaringly, most obviously in children and youth. Terry, God love him, always had a pot of money someplace where you can always shift some stuff around. And these guys have been around for a long time and they know how to do that. And you do it really well. I just, and thank goodness for the MA expansion and all that stuff. But I do think in looking at, and I know it's very hard to get past the day-to-day in budgeting for human services because there's so many things you don't control, particularly from the revenue side. But what scares me is that just everything points to more and more demand for your services. And either, we just got to keep hoping for that elasticity of revenue response, or we need to start making some, or a combination of that and start making some plans down the road. I mean, heroin epidemic, Sandusky legislation, increasing population in the county. So I think it's going to be a fun 3 to 5 years. I commend you all for everything you do. I know you financial people have it tough. I know the staffs have it hard, you guys. I think there's not a human services department I know of that doesn't have its staff working over regular caseload and stuff like that. So I appreciate everybody's efforts. But on the other hand, I think we do need to look at this down the road and start, developing some kind of coding scenarios for that, to the extent that it makes sense.
Yeah, I mean, the only thing I would add is we know that the demands for services are increasing, and, we need to get our arms around that, whether it's the federal, state, or county government. But, I mean, one of the things that I think out of a lot is, caregivers, especially for those with intellectual, the children with intellectual and developmental disabilities, where those folks are growing older and the caregivers are nearing the end of life. And how we're gonna, address those needs going forward. I mean, that's one of the things I'm very concerned about.
Yes, we have some stats on that. We have 50-some elderly caregivers identified.
And we still have a huge wait list, right?
We have a huge wait list. One of the things about those elderly caregivers of that period of time is that they want to keep their sons and daughters at home as long as they can. They don't want, when we come in and say we'd like to, help you make some plans, they don't want us there.
Mm-hmm.
They don't want to make those plans yet. So we keep trying all the time, but yeah, and then all of a sudden, then you have an emergency because somebody didn't plan and now they can't take care of the person anymore, so.
All right. Well, thank you, everybody. Thanks for all the work you've done.